We run the UK channelopathy service, the muscle channelopathy service. It's based at Queen Square, which I'm sure you all know because you all come and see us. And we supply the whole of the UK. It's funded by NHS England, so it's funded centrally by the government, which means that the local areas don't fund it. And it means that anybody can be referred in by their GP, by a neurologist, by essentially any consultant with an interest in neurological things, but even GPs. So that there should never be a barrier to you coming to see us. The idea, we aim for a fully functional service where you have lots of different aspects of care. So you have start off with your clinical assessment, you'll have your diagnostic tests, your neurophysiology, genetics, and we also have a functional expression service. I'll touch on that a bit later. And these are the conditions that we cover. So the myotonias, myotonia congenita, paramyotonia congenita, sodium channel myotonia, potassium aggravated myotonia, which is what it used to be called. And then the different types of periodic paralyses and Anderson-Torwell syndrome. And that is what we're especially commissioned to deliver. Now, just to give you an idea, there's been a little bit of change in the service, but these are the bulk of the team at the moment. So Professor Hannah and I run the service, and Dr. Vivek was our clinical fellow, has now been upgraded to a consultant. So she's a consultant on our service and also does clinics. We have Dr. Munnett, who's our pediatric neurologist who runs the pediatric service at Great Ormond Street. And then our consultant neurophysiologist, Dr. Nagendran, who runs the neurophysiology. He'll be the one that you see if you come in for any of your neurophysiology tests. And then we have our new research fellow, Dr. Asad, who's just started, and she does all of the research side of things with Dr. Vivek running the research arm of our service. So we have our specialist nurses. So Natalie James is our specialist nurse, and we do have a new nurse about to start who's going to be helping her out. So watch this space. Hopefully end of November he will start. And then Emma Scott, who is the pediatric specialist nurse. And then on the specialist physiotherapist side, we have Sarah Holmes, who I'm sure most of you already know, and Nicola Burnett, who does the pediatric side of physiotherapy. We have our research nurses, Ivona and Louise, who do all of the research side of things. So they'll often come and have a chat with you in clinic. And then on the administrative side, I'm sure pretty much all of you will know Jean Elliott, who is our amazing administrative assistant who does all of the day-to-day running of the service, and then Jackie, who oversees the specialist services, and Patricia Turner is the manager in charge. And then on the genetic side, the people who are looking at all of your genetic tests and trying to understand them and doing all the important testing that goes on to give you a diagnosis is Richa Sud and Gary McCarthy, who's just started with us. And finally, our electrophysiologist is Rupi Maniko, who does all of the functional testing. As I said, I'll mention a bit later. So that's the team, and that's what we all do, just so that you all know if any of the people you haven't met yet. All right, so now I'm going to talk about what's new in muscle channelopathies. I'm going to touch a little bit on what we talked about last time, just an overview of what the channelopathies are. But the idea is to just give you a bit of new information as well today, so that we're not repeating what we say every year. So I'm going to talk about what is a channelopathy, what are the types of muscle channelopathy that exist, what are the new channelopathies that we're starting to discover, how you manage your condition, what things are available for you and how that's changed, and what the new and existing investigations that we do for you are. So we'll start off with what is a channelopathy. And hopefully a lot of you already know this, but it's always good to go back over it. So a channelopathy is a disease, it's a condition caused by your ion channel not working properly. Essentially, that means that there is a mistake in your genes, in the thing that encodes what makes you you. And it's a mistake specifically in the gene that your body uses to make your muscle channel. Now, the gene mistake that can either make the channel stop working properly, make it faulty, or it'll stop you making the channel at all, so you don't make enough of the channels that you need. And all of these things come together to basically give you the condition that you have. If the channel doesn't work properly, basically what happens is your body stops sending the correct signals to either the muscles or the nerves, and that's what gives you the condition. So what are the different types of muscle channelopathy? So there are two main types we think of. So we talk about the non-dystrophic myotonias, and we talk about the periodic paralyses. So non-dystrophic myotonia that's the patients who have stiffness predominantly as their symptom and myotonia. And those with periodic paralysis will have episodes of weakness. And in reality, when we see you in clinic, we're thinking of things as a spectrum, and we're trying to work out where you lie on that spectrum so that we know what the best treatment will be for you. So do you have mainly stiffness? Is that your main problem? And that tends to be the main problem in people who have myotonia congenita. Or do you have a bit of stiffness and a bit of weakness, or more stiffness than weakness? Then probably more likely to have paramyotonia congenita. And then the other end of the spectrum, those who have significant weakness and lots of episodes of weakness, they often have Anderson-Torval syndrome, but they'll have some other things as well. So for instance, cardiac heart problems can also be an issue in Anderson-Torval syndrome. And then we have the periodic paralyses. So the hypokalemic periodic paralysis, which is you're having attacks of weakness because your potassium goes too low, and a hyperkalemic periodic paralysis where you're having attacks of weakness, usually because your potassium is too high, although it can sometimes happen when your potassium level's normal as well. So when we see you in clinic, we're trying to work out where do you lie on this spectrum, and therefore what treatments will be best for you. So as you saw with that spectrum, there are different types of channelopathy, and all of you will have one of these different types of channelopathy, but depending on what label you have, what genetic diagnosis you will have a slightly different problem. So if your problem is in this chloride channel here, you will have something called myotonia congenita, where the main problem is myotonia. If you have a problem in your potassium channel, that's usually associated with Anderson-Torval syndrome. And if you have a problem in your calcium channel, this one here, you will usually have hypokalemic periodic paralysis. And there are quite a few of you that will have this problem in their sodium channel. And in those patients, you can have both myotonia or paralysis, both of them together or separately, depending on whether you have paramyotonia congenita or hyperkalemic periodic paralysis. So you can see there are lots of different channels. There are even more channels than these, but these are the ones that tend to be infected in these cases. So what is myotonia? What are you experiencing day to day with your myotonia? So the term myotonia basically means difficulty relaxing the muscle after you use it. So your brain is telling your muscle to squeeze, to contract, and it gets stuck. It doesn't contract. It contracts, but it doesn't relax. It becomes stuck. And you can't open up your hand after you squeeze it, or you can't open up your eyes after you squeeze them. And that's the bottom line problem with myotonia. Now, how does it feel? So most patients tell us it feels like a stiffness or a locking or a cramping, and each one's individual, but these tend to be what people tend to feel. It can happen in any of your skeletal muscles, but what muscle is affected depends on what type of channelopathy you have. So if you have myotonia congenita, depending on the type, you tend to more likely have it in your hands or your feet or your back or your legs. If you have paramyotonia congenita, often people have it more in their eyes or with swallowing in their face. But each one is individual, and you'll probably already have a very good idea as to what your worst muscles are and where you have to be careful. And what is periodic paralysis? So periodic paralysis is when you have attacks of weakness. Why does it happen? Well, it happens because the muscle stops getting the signals it needs. So it's the opposite of myotonia almost. Rather than you sending a signal to your muscles and telling them to contract and they get stuck, it's the opposite. You send the signal to your muscles to move, to contract, and it doesn't work. It doesn't receive the signal and you feel weak. Often people have particular triggers. It's not always the case, but often people will notice that it's triggered by particular foods or by cold weather or by exerting themselves too much. And it's really important for you to have a think about what are your triggers, what are the things that make your attacks come on more often, and try and reduce those things, try and target that. The triggers for weakness, again, just like myotonia, the triggers for weakness differ depending on which type of periodic paralysis you have, which channel is not working in you. So for instance, if you have a calcium channel problem, you'll be much more likely to be triggered by big carbohydrate meals, eating lots of pizza or pasta at nighttime. Whereas if you have a sodium channel problem, you might be more sensitive to potassium, so eating lots of bananas. But in pretty much everybody, excessive exercise, strenuous exercise will often trigger an attack. Now, usually in between attacks, people don't have symptoms, but some people do, and some people take a long time to get out of their attacks. And some people find that later in life, they stop having attacks so much and tend to have more mild weakness in the background or background weakness. And one of the things we try very hard to do in the clinic is try and work out ways we can stop you having the background weakness and how we can target that. Okay, so what about the new things about channelopathies? So what new channelopathies have been discovered? Now, Dr. Vivek's going to go in much more detail about all the research side that we do here, but this is more about the research that's available from other centers. So what we're discovering is, because we're doing lots more genetic testing and lots of different types of genetic testing, we're discovering other types of channelopathies. So the two newest types that there've been lots of work done on recently are the congenital myopathies and congenital myasthenia. So these conditions are slightly different from the usual ones we see, and they tend to start in early childhood or sometimes at birth. And patients tend to have weakness, but also may have weakness continuously in the background, but with also episodes of weakness. Now, actually, we can diagnose these new conditions with the same panel that we use for our patients who already have channelopathies. So we haven't had to change things very much, but these conditions look very different. And the important thing to note is you're not going to get these conditions having already got your current diagnosis. These are for patients who are undiagnosed who are coming through. But it's just to tell you that these things are always evolving and we're discovering new things all the time. All right, so I thought we'll talk very briefly about managing your condition, because for a lot of you, this is probably the single most important thing. So what do we already know? Well, we know that avoiding triggers is probably the single most important thing you can do to help your condition. So avoiding sudden changes in temperature. Some of you will be very cold sensitive, some of you will be heat sensitive, and often it's that change going from hot to cold rather than necessarily being in a hot environment or being in a cold environment. And then I talked briefly about food. So some of you will be very sensitive to potassium levels. Some of you will be very sensitive to carbohydrates or sugars. And it's about keeping a diary, working out what is it that triggers you and trying to avoid those things, or at least reduce them a bit. And I think for everybody, strenuous exercise, suddenly doing a lot of exercise and then often stopping after that, that can often be a big trigger for people. So we don't want you to stop doing exercise. What we want you to do is be gentle with your exercise and slowly build up, because that's much, much better for your muscles than suddenly boom or bust going for it. So how do we treat each of these conditions? So with myotonia, we currently tend to use mexiletine. There's good clinical trials. We did a big trial here in 2012 where we showed how effective it can be and it's safe in the long term. But there are certain selection of patients who can't have it because they have heart problems, because it causes really bad reflux and feeling of acid in your stomach. So what we've started to do is use lamotrigine a lot more. And Dr. Vivek, I'm sure, will talk to you about the big study, which I'm sure a lot of you here on the call were involved with. And we're very grateful for everybody being involved. And we're starting to use lamotrigine more and more, especially off the back of that study, where we find it's well tolerated, that people find a good effect from lamotrigine, but also it has the advantage of being safe in pregnancy, which very few of our other medications are. People don't get the reflux symptoms or the cardiac symptoms, but the one thing we always say to everybody when we start it is about 10% of people will get a rash, and you have to watch really carefully for that. So the treatment's up and coming, mainly lamotrigine, and we're looking out for other treatments. But we also find that magnesium is useful. That can be oral, that can be magnesium lotion. There's a magnesium spray, which some people find useful, and their bath salts. All of these things can be really good for myotonia when the other medications aren't working, or that you can use on top. We also sometimes use carbamazepine, phenytoin, acetazolamide, quinine. We tend to use these less and less now because the other two medications are so effective, but it means there are other options if you haven't had any effect with mexiletine or lamotrigine. What about periodic paralysis? So in hypokalemic periodic paralysis and Andersen-Tawil syndrome, we will often give potassium supplements, especially if you're running at a lower level. Acetazolamide tends to be our main treatment for this condition, but we will add on a potassium-sparing diuretic, a miloride or spironolactone, if you're running your potassium very low, you're having lots of attacks, and we think we might get things better with that. There used to be a medication called diclofenac. We can't prescribe it in this country anymore. That has shown effect in the past, but we're having to make do with acetazolamide and potassium-sparing diuretics at the moment. Hyperkalemic periodic paralysis, again, acetazolamide, because it seems to level out your potassium levels, works for both of these conditions. And then we do use these thiazide diuretics, so things like benzoflumethiazide. But what we're starting to realize is that patients who have problem in their sodium channel can have both high and low potassium attacks. This is a new thing. We didn't know about it a few years ago, but we're starting to see it more and more. And so we're having to be careful not to drop potassium levels too low in those who have hyperkalemic periodic paralysis. Now, what do we know about these new types of attacks that we're seeing? Well, patients tell us that they feel different to their high potassium attacks. So the low potassium attacks tend to feel a bit more generalized, and maybe people feel a bit weaker. So we're going very carefully with diuretics. And some patients end up, when they end up having a really low potassium, end up on Sandocaine alongside, which is slightly counterintuitive for us. But what we will say is, to those of you who have sodium channel variants, so you have a condition which affects your sodium channel, if you have an unusual attack, please get in contact with us. Please try and do a blood test at the time, because it may be that you're having this new type of attack. Okay, and then I wanted to very briefly, before I hand you over, talk about pregnancy and anesthetic, because that is something that we don't always touch on. And I know it's not relevant to all of you, but it's important for half of the population at least. So what we commonly find is that patients worsen their symptoms in pregnancy. And some of you will have been diagnosed in pregnancy, because that's when your myotonia or your episodes of weakness first properly kicked in. So pregnancy does make things worse, and it's really important that you tell us if you're feeling worse in your pregnancy. What we do find, however, is that people recover back to where they were before, after they deliver. So things settle down once you've had the baby. There are some treatments that are safe in pregnancy, for instance, lamotrigine, magnesium, but there are some treatments that we'd want you to stop in pregnancy because it's not safe for the baby. And so my bottom line at the end of the slide is going to be, please, please, please come and tell us if you're thinking about getting pregnant or you are pregnant, because we want to support you through that time. We want to make sure you're on the right medications, and we want to make sure that your delivery goes according to plan. So from a delivery point of view, we recommend that you give birth on a labour ward. You can have a normal delivery, but we have a low threshold for going in for an assisted delivery if you've been pushing for a long time, if you're getting tired, if you're feeling weak or very stiff. That's the point at which it's probably time for a little bit of help. In periodic paralysis, we want them to monitor your potassium levels, make sure they stay level during the delivery. And you can generally have most of the things that all women have in deliveries, and you can definitely have an epidural and any kind of local anesthetic. And what about having an anesthetic? So this is probably more applicable to more people. It is really important that you tell the surgical team that you have a channelopathy and you're under our care, so that they can contact us and we can put together a plan with them. During the anesthetic and just before and just after, it's really important you're kept warm and well hydrated. And certain types of anesthetic can precipitate a worsening of symptoms, and you might need a little longer recovery time. Surgery itself can precipitate an attack in some people. So just be aware of that and just give yourself a bit of extra time for recovery afterwards. You must never, never stop your medication suddenly before surgery. You must speak to someone before you do that. And if you're worried about whether you can take your medication on the day of surgery because you're nil by mouth, just have a chat with your surgical team or your anesthetic team just beforehand. Some patients can only have certain types of anesthetic, and we can advise you about that, and we can advise the team looking after you about that. And patients who have Anderson-Tawil syndrome, they'll need cardiology input before they have surgery, as well as all the other bits and pieces. So please contact us or your anesthetic team well before your surgery so that we can help, so we're not trying to advise everybody the day before you go in for your operation. And we have individual anesthetic plans for everybody. We can send it out for you. Most of you, we will have done that at some point, but if you haven't had it and you want to have it so that you always have something in case you need it, just tell us and we can do that. As I say, we do it on an individual basis for each person. So it won't be the same as another patient with a slightly different condition. All right, so now I'm going to touch on investigations and then let Dr. Nagendran talk about neurophysiology. So what investigations do we use? Well, apart from the usual blood tests and things, we're starting to use MRI tests more and more. And I think Dr. Vivek will probably touch on this as well. So we use MRI because it can help with diagnosis. So in the diagnostic stage, it can help us monitor your condition, but it can also help us understand whether your condition is getting worse. If you're not sure if things are worse or whether we need to increase the treatment, often we'll suggest doing an MRI just to see what things look like. And we have functional studies. So this is for when you are first diagnosed. So when you're first diagnosed, we have a electrophysiologist who specializes in this. And if you have a change in your genes that is different, that is new, that we don't completely understand, then often we will send him the details of your genetic change and ask him to have a look under the microscope at channels to see which have that change, to try and understand how your channel is misbehaving, why it's giving you the condition that you have. And that's a very specific service to us. There aren't many places in the country that do this for other conditions. So I'm going to stop there and I'm going to ask Dr. Nagendran to talk through what's changing in neurophysiology, because we may be asking you to come in to do some neurophysiology tests, and we've got some new things coming through at the moment.
Yeah, thanks very much, Deepa. As Deepa mentioned, I don't want to sort of rehash everything we mentioned last year, because I think most of you on the call probably heard all of that. So we're just going to focus on, again, what's new as of this year in neurophysiology. So next slide. So most of you will have had some of these tests. So at the moment, our current testing involves giving you some electric pulses and using a fine needle to test the nerves and muscles. And we use the short exercise test, which is quite helpful for disorders involving myotonia. We use something called the long exercise test for disorders involving periodic paralysis. And these are very good and well established, but they're not perfect. In particular, they can sometimes be poorly sensitive if people don't have very frequent attacks, which again can lead to delay in diagnosis, one of the big problems in channelopathies. It does depend on patient cooperation or subject cooperation. And I mean, it happens rarely, but if we did need to assess somebody who is sedated or very unwell or on intensive care, it's not something that we would be able to do. Also, when you have patients who are, even though again, it's not very common, people who are elderly or drowsy when we're doing the test, cooperating with the exercise test can sometimes be a challenge. And overall, the testing can be time consuming, particularly the long exercise test. And next slide. So over the last 10 years or so, there has been an emerging technique, which are called broad, I mean, there's a group of techniques, but it's under the umbrella called muscle excitability studies. And it does need some specialized software and specialized hardware, which is also quite expensive and not very widely available. Thankfully, we are already using that kit for some of the patients we see with cramp, where we suspect that the problem isn't actually related to muscle, but might be related to nerve. And within the field of muscle, these techniques are very much still at a research stage, but they may be helpful investigating properties of overactive or overexcitable muscle, underactive or underexcitable muscle. Also other aspects of muscle problems, such as muscle fatigue. And some of the raw data that we collect, you can see on the right-hand side. Next slide. And essentially, the reason why this is interesting is that it does hold promise, particularly for patients who have channelopathies, where we know the problem is mainly around single muscle channels on the muscle membrane. The reason is that this technique, compared to, for example, EMG or nerve excitability studies, is a purer way of assessing what's happening on the muscle itself. It doesn't depend on the nerve as in other techniques. And we already have some proof in animal studies and other studies that have been done on humans and pilot studies elsewhere. and it has shown some effectiveness distinguishing different kinds of myotonia and periodic paralysis already. And overall, it's just going to improve our understanding going forwards. Next slide. And in terms of the benefits, compared to the other studies, I mean, everybody would know who's undergone these testing already, that obviously there is some you do get electric pulses, you do have a fine needle that's inserted. The good thing about this is that even though there are plenty of electric pulses, you only put the needle in once, it doesn't have to go into lots of different muscles. And overall, it seems to be very, very well tolerated by people who've gone through it. It's less dependent on cooperation, so it sort of broadens the population that we can use it on, even if you're very unwell on intensive care. And again, yeah, so we've mentioned it's sort of similar to the sort of current testing methods we have at the moment. So there's nothing to suggest it would be poorly tolerated. And on the left-hand side, you can just see roughly what the setup is. So there's a couple of very fine needles that go into the leg and some electrodes there providing the stimulus. Next slide. So Dr. Karen Sutterlin has kindly decided she's going to help lead this study and collaborate with us. So we're going to do a pilot study is the plan for the coming year. And if successful, essentially the benefits that we might get is that it might reduce the length of time we have to spend testing patients. It might increase the sensitivity, so reduce the number of diagnoses we miss, particularly when events are rare. And as we said, so it should hopefully help improve on the delay to diagnosis at the present time. And that's it really, watch this space.